Good evening, everyone. A warm welcome to all of you to this chapter 51st in the series of masterclasses brought to you by Indian Association of Surgical Oncology. To deliver the welcome address for today, we have our president, Dr. P.K. Das. Sir, the mic is yours.
Thank you, Susan. So good evening to all. So I welcome to all of you for this 51 chapter of IASO Masterclass. As you know, the IASO Masterclass is the flagship program of IASO academics, and it has been running last 3 years, soon after and during the COVID. And it has become a very, very successful and under the guidance and under the leadership of Dr. T.S. Rao and Dr. Srijan. Of course, 4 leaders from different zones, past president, they have been working and advising us as a advisor all the time. So I must welcome them also, Dr. Raj Govind Sharma, Dr. Arnab Gupta, Dr. Sadasivam, and Dr. Sanjeev Misra. So this time it is a still interesting topic, recurrent breast carcinoma. And we have Dr. Vani Parmar, who is a very well-known figure. Everybody must be knowing her. And this is, I must welcome her. Dr. Vani, please, welcome to this meeting. I must also welcome Dr. Nisha Hariharan, who is from Hyderabad. And let me also welcome our examinees, Dr. Radharaman Mandal and Sunita Jairani. And last but not the least, I must welcome our secretary, Dr. Chandra Mohan, who has been an inspirational source for us during all the master classes and giving a vote of thanks at the end. So without wasting much time, I must hand over the mic to Dr. K.S.
Thank you, sir. A few instructions for the session. The first 1 hour will be a mock exam to our examinees, Dr. Sunita and Dr. Radha. We request you to give to-the-point answers. If you don't know something, just pass it along. It saves us time and maintains the flow. To our moderator, we request you to please address the examinee by their name when asking a question so that there's no confusion who's supposed to answer. And we also request you to ensure that both of them get equal opportunity to answer. To both our examiners, in interest of the online viewers, although this is a mock exam, we'll request you to give the expected answers to the questions that have been incorrectly answered or remain unanswered at examination. For the participants, there's a chat box as well as a Q&A box in your control. We would prefer if you post your queries as well as your inputs at the chat box so that it's visible to everyone. I'll remind the moderator at 30 minutes and at 60 minutes about the time. With that, I hand over the screen to Dr. Nisha Hariharan to take the mock exam forward.
Thank you, Mr. Rajan. Share my screen with you. Is that visible?
Yes.
Yeah. This IASO Masterclass is a great platform, and we have a very interesting topic today. Recurrent breast cancer is something we come across daily, and it's not an easy task to make a decision on how to proceed forward. So we have 2 cases today that will hopefully cover all the aspects. So I'll start with the first case. So this is a 36-year-old lady. She's a premenopausal lady. She was diagnosed with right breast cancer in 2019. Clinically, she had a 2-centimeter lump close to the nipple areola complex with no significant palpable axillary nodes. She has a family history of breast cancer in her mother, who was diagnosed at the age of 65 years. After appropriate workup, she underwent a right breast conservation surgery with sentinel node biopsy in February 2019. Her histopathology report was a 1 centimeter invasive ductal carcinoma grade 2. DCIS was present around the tumor. LBI was absent. All the margins of dissection were free of tumor. Her sentinel nodes were negative for malignancy. Her ER was 90%, ER 96%, and HER2 was negative. She underwent a genetic test at the time and she came out to be BRCA negative. She proceeded to complete her adjuvant radiation and was then started on tamoxifen.
Nisha,
Madam,
got you here. So we will just quickly run it with each slide so that we are actually done with the questions for that particular case capsule that you started.
right, madam.
So a quick run through. Let me have either of them. Let me start with Sunita. Sunita, from this brief history, can you just tell us a quick run on what you think was this disease stage and her presentation? What do you think important in that history that has been just presented?
Okay, ma'am. The age is younger age. She comes under the younger age group and she is a premenopausal lady with a family history of breast cancer, and it is in stage 1, but her high risk was DCIS is present and she is hormone positive, ERPR positive, HER2 negative, and her genetic testing was negative.
Okay, hold on. So, Dr. Radha, do you think that this DCIS present is a high risk feature in this patient?
No, ma'am.
Why not?
Because presence of disease does not change any management at this stage of the patient.
Okay, if I counter that and say that all margins are free of tumor, but if DCIS was present with a positive margin, would that have changed your opinion?
Yes, ma'am.
Sunita, do you think now that DCIS being present is an important risk factor, or DCIS with an EIC positivity is the one which changes the risk in her?
Yes, ma'am. EIC will change the risk.
So if there is margins which are free of tumor, DCIS present does not make it a high risk for local recurrence. Anything else do you think in this brief history and management that you think could have made an impact on her management? She's an ERPR strong positive, HER2 negative, right? Small tumor, T1, grade 2. She's been given adjuvant radiation and hormonal therapy. Is there anything else in this management that could have changed the outcome from current evidence? Any one of you, quick answer. Radha?
Ma'am, Ki67 should have been checked, and if the Ki67 is high, the patient would have been luminal B. Then maybe she would have been a candidate for chemotherapy also.
Good. So we needed to have at least the proliferation factor checked here, which we didn't do, and we have not given her chemotherapy. Her age is young, 36-year-old. Anything else that we could have done or added in her treatment to have changed our outcome?
Ovarian suppression could have been added.
Two important things that we should have had in here. One is that we should have checked the Ki67. If Ki67 was high, in spite of it being ERPR positive, HER2 negative, and nodes negative, we would have considered her for some kind of an adjuvant chemotherapy. Secondly, of course, an ovarian suppression added to tamoxifen would have improved her outcome. There is no other indication here other than her age, which is the factor in this particular. We can move to the next.
Yes, ma'am. Going on. Okay. She continued to be on routine follow-up with us. In January of this year, she presented with the following mammogram. These are the images for the right breast. The contralateral side was normal. One of you, Dr. Sunita, could you maybe read that mammogram for us?
Yes, ma'am. Oval-shaped mass seen in the central quadrant of the right breast. Central.
I think there is an arrow already pointing to it.
No.
Yeah. So what is that?
Ma'am, an oval lesion is there, ma'am.
Are you able?
Would you, in this two thing, will you call that central or is it an upper central?
Upper central, ma'am.
Right, upper central. Remember, it's an MLO view. This is not really an upper central. It could be actually upper outer and central. So it's a little more on the, I would put it at 11 o'clock position. And the space that it's occupying is the retromammary space. What is your differential on this lesion being seen?
It may be ipsilateral tumor recurrence, or it may be also benign, ma'am, because it is oval in shape. And there is no mic.
Would you have wanted the previous mammogram to have commented on this lesion, first of all? We are talking, I think 2019 was the first diagnosis.
Yes, madam. She was diagnosed in 19.
4 years looking at this lesion, you would want to know whether this is a new lesion or not, and not just take it as just because you've seen a lesion, you want to call it a recurrence. All right. So comparative mammograms are a must. Yes, Radha, what is your differential on this lesion?
I would like to compare with the previous mammogram. If it is a new finding, then I would probably think about the recurrence, considering the patient's young age.
What if it was a persistent thing that was seen previously but masked because of her density of the breast? Mind you, this patient is a 36 premenopausal at the time of treatment. Now she's received tamoxifen for some time. What are the changes in the breast that comes in after tamoxifen treatment?
There may be change in fibroglandular pattern of the breast.
That's
Also fibroadenosis.
well, I wouldn't call it fibroadenosis, but something that may have been pre-existing in the retromammary would have been masked. What is the possibility of there? What is the common thing that you find there? A lymph node, right? So it could have been a missed lymph node, not seen previously because of density of the breast, and which is now, because of the rarity of the breast that's come in after tamoxifen treatment, could have become prominent. All right. What is the next? Nisha, you can continue.
Yeah. So how would you like to proceed? What investigations would you like to ask for this patient?
Sunita, we start with you.
Yeah. So she was otherwise all right on routine follow-up. She got a mammogram done, and this is what we identified. So what next? How would you like to proceed, Dr. Sunita?
I would like to proceed with the ultrasound-guided biopsy of the lesion, ma'am. After comparing with the previous mammogram, if it is a new finding, then I want to confirm my diagnosis with the biopsy.
Okay.
Okay, wait. Radha, do you have any difference in opinion of what other investigation you might want to do? And if so, why? If not, why?
No, ma'am, I just want to confirm my diagnosis with a USG guided biopsy, core biopsy.
So both of you agree on that? You don't want to do an MRI on this?
If the biopsy comes out to be malignant, then probably I will ask for MRI.
How would an MRI add value after you have done a biopsy?
If I consider this patient for repeat BCS, then I'll plan for MRI before the biopsy.
We'll come to
After
the
MRI.
management later. Let me first keep it here. Let's keep it simple. We're not looking at a complicated management. We're looking at a simple management for this. You have a patient who had a primary near the NAC. Now you have a second lesion, which is in a different quadrant in the 11 o'clock position, right? So you have different area now affected with a lesion, with a malignancy if positive. We're getting a biopsy. So would you already start thinking of doing a re-BC, or what would be your management?
Ma'am, this can be a second primary. So I will do a MRI first to check the other quadrants, also the contralateral breast.
So in this particular patient, let me bring it down to now this particular patient, you can see that the breast is not very dense. I can't appreciate very well, but there are patchy calcifications that I can see scattered. Am I right, Nisha?
Yes, madam, it's visible.
Though they look like coarse calcifications, I'm not very sure about the nature of this. And I can even see some linear calcification in the exact central part if you see the. So I'm a little concerned about multicentricity in this patient. So I may ask for a MRI for that specific reason. Okay, but it is not a 100% indication, because a management, whenever there is a second primary in a different quadrant in any patient who's had a BCS and received radiation, as we know from the history, the plan should be a mastectomy unless proven otherwise. Deviating from that plan will be different based upon the discussion you have with the patient. So let's leave it at that right now. MRI, because I see some calcification is scattered. And the only indication for MRI here would be if the patient is asking me, is it possible still to save my breast? All right, next.
Yeah. So these are the investigations we got for her. Her breast imaging was a 3D mammogram. The mammogram and the ultrasound revealed an irregular isodense lesion. It was hypoechoic on ultrasound. It measured 9 by 5 millimeters. With heterogeneous calcification. It was in the upper inner quadrant. She had small reactive right axillary nodes. The left breast and axilla were normal. Her routine blood investigations were normal. She underwent an image-guided core biopsy of this lesion. The biopsy report was invasive carcinoma grade 2, ER 95%, PR negative, HER2 negative. She underwent an FNAC for the right axillary node. That also came out to be negative. She underwent a PET CT scan for her metastatic workup, which demonstrated a hypometabolic lesion in the right breast, and there was no evidence of any other metabolically active lesion elsewhere in the body. So,
or rather, any one of you? What is the important few points that you've got here? Tell me that.
Dr. Sunita, would you like to go first?
Yes, ma'am. So now the biopsy came as positive invasive ductal carcinoma grade 2, so which is an recurrent, but the quadrant is different. And also the receptor status, previously she had ER, PR positive, and now she has only estrogen receptor positive. And also the metastatic workup, it's confined disease, it's not elsewhere in the body.
I will make one statement.
And K.
Okay, one minute. What makes you say this is recurrent breast cancer? Why not a new primary?
New primary, yes, ma'am. It may be new primary because it is in the different location.
It is in a different location. A bed, one. The previous one was closer to NAC. This is in the retromammary space. It's obviously a new primary, right? The only thing I would like to know is there DCIS present in this lesion or not, which has not been reported in the core biopsy? Nisha, was there a DCIS in this lesion, which has not been reported?
There wasn't, madam. There wasn't in the biopsy.
Right. So even though the grade is same, what really clinches primary versus a recurrence versus a new primary is in this situation would be the biology. Okay. Had this been a completely different kind of a tumor, which is like ERPR negative, HER2 positive, I would definitely say this is a new primary. But currently, the only indication of it being a new primary is the distant site. It is not in the tumor bed. It's in the distant site compared to the primary. And that is the reason why I would still consider this as a new primary. Is there anything else? You see, there is a change in biology. Can a recurrent breast cancer change the biology? Radha.
Yes, ma'am. Receptor status can change.
Yes, tell me.
From ER positive can become negative or the vice versa. Also the HER2 status can change.
So the commonest ones which change are ER or is it PR?
Commonest change is ER.
You're sure about that? Not very sure. So the commonest that changes actually is HER2. The commonest that can change is HER2. And next to that will be a progesterone receptor. ER is not that much of a factor which changes. It's the progesterone receptor which may change from primary to a recurrence. So in her, you see there is a difference. I'm not saying this is because it is a recurrence. There is still a high suggestion of this being a new primary because of its location. And of course, the biology being slightly different. And unless and until somebody tells me there's GCIs in this lesion, it may be a little hard to say this is purely a new primary. How far was it from the original? Original was near the NAC, right, Nisha?
Yes, madam. It was closer to the NAC. On the breast, surface marking wise, it was about 5 centimeters away, the new lesion that appeared.
Yes. So obviously this appears to be a new primary and I would still go by that. All right. Anything else in this? FN node has come as reactive now again. So will you depend on this FNAC to decide on the auxiliary treatment? Rather? Yes or no? I just want an answer.
Yes, sir. Yes, sir.
You will depend on this. So you're not going to address the axilla in this situation because your FNAC of a node which has been seen on imaging is negative. You're sure that the drainage pathways are still intact. And the node that you're seeing is the node that will be called the new sentinel node. Is that so? No evidence to it. When we move on to the
No
next.
evidence.
Can you tell us what changes do you expect in a patient who's undergone radiation in the pathway that madam is asking, the lymphatic pathways?
We are talking of 4 years down the line, patient has had a BCS and radiation and now presenting 4 years later with a new primary. Would the lymphatic pathway still be the same in this patient?
Lymphatic pathway won't be same because most now the axilla is already addressed. But most lymphatic pathway intact is the internal memory. The main drainage may go either to internal memory or to the infraclavicular or supraclavicular.
Either ways, we don't know where it is going, but it is not going to be the systematic sentinel node that you would see in a primary cancer. One, because there's diffuse breast fibrosis, lymphatic will undergo fibrosis. Secondly, you already tampered because you've done a sentinel node biopsy previously. You've already cut the lymphatic pathways to the axilla. You are not going to depend on a sentinel node biopsy post BCS recurrent lesion in the breast. All right. Anything else, Nisha? Can we move to the next slide?
Yes, ma'am. Moving on.
All right. We seem to come to now some discussions here. Okay. Let's take one at a time. Patterns of local recurrence. Sunita, you want to answer the patterns of local recurrence post breast conservation surgery, since this patient had a breast conservation surgery and radiation.
Okay. Patterns of recurrence in local after BCSS, ipsilateral breast tumor recurrence or new primary is local. If it is loco-regional, then the axillary nodes may be involved or supraclavicular node.
Just add to this much. What she has said is only local, primary, local recurrence and loco-regional. Can you tell me what are the incidence of local tumor bed recurrences? How often do you find a recurrence out of it? Can you have a breast recurrence away from the tumor bed as well?
Yes, ma'am.
What is the tumor bed recurrence? What is the incidence of away from tumor bed?
Tumor bed recurrences 2.3 to 5%, and away I don't know.
Okay, we are talking of two different things. One is what is the incidence of a local recurrence in post breast conservation surgery. Within the recurrences, I'm asking you how much percentage of them will be in the tumor bed itself. When you're talking of the 2 to 3% having recurrence, where will there be majority of them be found? That is the percentage I'm asking you. Radha, can you answer? Because we don't have much time here. Let's not just wait for it.
We can have in breast recurrence. In the breast tumor bed, the recurrence rate is around 3 to 5%.
Wait, Radha.
And outside the tumor bed, it's less than 1%.
Radha, you're repeating what Sunita said. I want to know tumor bed recurrences. What is the percentage?
Around 3 to 5%. And in Neo series, it's less than 3%.
No.
Dr. Sunita, can you tell us what you understood by tumor bed recurrence? What did you understand by that?
Tumor bed recurrence is the place where we have treated with radiation. I mean, after post BCS, the radiation boost volume has been given to the tumor bedside.
So you are saying that is 3 to 5% incidence. Somebody has to mute. So tumor bed recurrence is something that is, when you see a local recurrence in a breast, majority of the recurrence are not about incidence of after a breast conservation therapy with radiation. That would be 3 to 5%. But 80% of recurrences occur in the tumor bed. 5%, 80 to 85% of them will be in the tumor bed. Chance that you may find recurrences away from the tumor bed. Hence, we had this lesion. There is a possibility that this lesion could still be a recurrence and may not be a new primary. So we have to keep both in mind when we are managing this. Okay. True recurrence versus a new primary. I think we have discussed this already, Nisha. We won't get into it.
Yes, ma'am, we have.
All right. How do we proceed for the breast? Radha.
I would like to do a comprehensive metastatic workup with whole body PET scan.
I think we already have the report. The metastatic workup said there was a lesion only in the breast. There was no distant disease. Now tell me, what is your next line of treatment?
What is your plan for the breast? How would you proceed?
I'd like to, as the recurrence is operable, I'd like to go for resection of the primary as well as axillary lymph node dissection.
So you have started to plan this patient without discussing anything with the patient herself? She had a mother who had breast cancer. She herself was young when she got her primary tumor. She's had a breast conservation surgery. She's come back with a relapse. Have you assessed her psychologically as to, is she willing to have a conservation? Or is she stressed because of her recurrence and she would rather have a mastectomy and a whole breast reconstruction? Your approach should be that I would like to discuss with the patient and ask her what is it that she wants. What would you advise her and what is it that you would do after discussion? As a clinician, as a surgeon treating this patient, what should you be advising this patient?
I will advise her to undergo total mastectomy and axillary lymph node dissection. However, if she wants, she may undergo BCS and repeat SLNB. But I should remind her that the data regarding the outcome of this procedure is very not robust.
Sunita?
I will counsel the patient regarding both ways of treatment about BCS and total mastectomy with axillary node dissection. But I would tell the patient that I will prefer for total mastectomy.
So as I see both of you, Radha and Sunita, you seem to be kind of biased towards offering a conservation to her, knowing her history, knowing the fact that she had a family history. Yes, she has a BRCA which is negative. Her genetic workup has come out as negative, but both of you are inclined to talk of BCS first and then mastectomy later. Because I find in your answers, you're saying that you're inclined to first think of a breast conservation. The advice is what you give based on evidence. Based on evidence, you would suggest this patient to have a mastectomy, not to have a conservation. But if the patient is keen on conservation, in spite of knowing the fact that there would be a higher risk of a relapse and a distant progression, that is the situation where you would then work her up to talk about breast conservation as a reconservation. Remember, she's already radiated. She's got a relapse in a radiated breast. The outcomes in such a breast is always poor. This is a post-radiation recurrence. I would differ here if she had had a accelerated partial breast irradiation in the first sitting, which she won't get at the age of 36. Had she been 20 years older, or even say 10 years old, 10 years older, 46, and she had had a accelerated APBI at that point of time, a re-excision and doing a whole breast radiation would then be an ideal treatment for her. if she's so keen on it. But if she's an already radiated breast, to then reconsider her for doing just a limited lumpectomy is not really an advisable treatment for her. The evidence to this is lacking. Okay. So I think both of you should then look at, answer should be a mastectomy first, a conservation only if she's very keen on it, under certain specific conditions with a clear counter. She may be at a high risk for relapse. How do we proceed for the axilla? She had a sentinel node biopsy in the previous. She's got an FNAC saying reactive node. We did discuss this briefly in the previous. So Radha, what's your opinion now?
My opinion is to go for axillary lymph node dissection. And if she is very keen for not going for axillary lymph node dissection, then she may undergo a repeat SLNB. But again, I would remind her that the data is not robust and there may be recurrence.
There is no data. For a re-SLNB, there is no data. Because you know that the lymphatics are going to be altered. But if you don't want to and you want to do a limited dissection in her, I think it's still going to be a systematic spread the way you see in an upfront untreated breast. It may not follow the sequential pattern, right? But is there an alternative method for assessing? Since there was no uptake in the axilla on PET as well, there was only in the breast. Could you do a low axillary sampling maybe? Something that does not follow a lymphatic flow is a method that you could possibly assess or use to do a limited dissection in this situation. But these are nothing, none of these have any evidence to support. These are all exceptions to the rule. But if you were to look at this patient who's had a second relapse, primary or a relapse in the breast, the axilla should be addressed as a clearance in this situation. It cannot be a limited dissection. Nisha, do you have anything to add to that?
I agree, madam. I just wanted to ask, do you understand why low axillary sampling is an option we can offer here? What advantage does it give you that a sentinel node biopsy does not?
I have no idea about.
Do you know what the procedure of low axillary sampling is? Any one of you? Sunita, Dr. Radha?
Not at all.
No.
All right. Looks like we need to get that paper in some time first. So this is a situation where you're looking at lymphatics being altered, lymphatic drainage being affected by two things, one surgery, second radiation. Now, low axillary sampling looks at an anatomical dissection of the lower levels of the axilla below the intercostobrachial nerve and takes out all the fat and lymph nodes in this area. So even if the lymphatics are altered, you may be able to pick up nodes. But I would be wary even offering them low axillary sampling because sometimes it can bypass completely the lower axilla because of the surgery and skip metastasis may occur higher up. The only supporting, well, I wouldn't say even a very strong evidence is your PET saying no uptake in the axilla. FNAC has no bearing, no role. I don't think that would have helped me to decide to not do something. It's better to always address the axilla completely in such situations. How do we proceed for adjuvant and role of reconstruction? So let's go for surgery first. Let's see role of reconstruction in this patient.
Dr. Sunita, do you want to take that?
Answer to it anyway. Sunita, can you just give a quick answer? Role of reconstruction?
Yes, ma'am. There is a role. First, I'll discuss with the patient, ma'am. After total mastectomy, we can give reconstruction, ma'am. There are various options. With the first breast implants or flaps, ma'am. Flap like lattice.
First choice. This is a radiated breast.
Yes,
Which one do you prefer, Dr. Sunita?
Flap reconstruction, ma'am.
Flap reconstruction. I will just counter question you on only one aspect. In the breast reconstruction, do you think she can have a skin-saving mastectomy? Can she have a skin-saving mastectomy?
No, ma'am.
Why not? You were willing to do a limited surgery and do a breast conservation, then why are you saying no to a skin-saving mastectomy? My worry is the parenchyma having high risk for recurrence, not the skin. Why can't you do saving mastectomy, whole breast reconstruction using a DF take out the NAC and do a nipple reconstruction there later on. Why not? Don't you think that gives her a better, safer option as compared to offering her a re-lumpectomy? Radha, you were the one who were keen on doing a BCS for her, right?
Skin sparing mastectomy can be done because it's already 4 years after the radiation, and vascularity should not be compromised now.
So it's an option that you can definitely offer to a patient to have a skin-saving mastectomy. Now, whether nipple to be saved or sacrificed, I would do a nipple sacrificing because I'm not sure where the primary was. It was close to the NAC, the first primary. I would do a nipple excision, circular, do a skin-saving mastectomy, do a whole breast reconstruction using a free flap, and nipple can be reconstructed at a secondary stage. I think that would give her at a young age an option of having her breast intact. I wouldn't call that a breast conservation, but a breast intact because she can have a whole breast reconstruction. Implant would not be your first choice because she's radiated. Post-radiation, the complications are much more with an implant, and you would not want to put her through a second stress of having a rejection of the implant. Okay? All right. What about the adjuvant? Are we discussing it here?
Just a brief mention, madam. Just the principles.
Was a 36 premenopausal who had received no chemo earlier, had received tamoxifen and radiation only. And now she's come back with a tumor which is again HER2 negative, ER strong positive. What do you think is a possible adjuvant for her? She's got no distant metastasis. You have addressed her primary completely. You've done a mastectomy, whole breast reconstruction. And her nodes are also negative in her clearance. What do you think would be the adjuvant for her? What do you take from this? Simple. She's been on tamoxifen.
Now we have to change tamoxifen from aromatase inhibitor, ma'am.
1 minute.
And also ovarian suppression.
So you said from tamoxifen to AI.
AI and also ovarian suppression.
Correct. One small thing here. What do you learn from a patient who's had 4 years of tamoxifen and has now relapsed after 4 years?
It tells about secondary endocrine resistance, ma'am.
Right. So she is hormone responsive and she has now developed a resistance to tamoxifen. Right? She also got contralateral breast in no primary there. So the tamoxifen is also working in the contralateral breast as well. Right? She's a young patient. Now, ovarian suppression and a second-line hormone is a good option for this patient. Rather, do you agree or do you think that she's had an isolated loco-regional treatment? What is the evidence of a chemotherapy in her? Systemic chemotherapy.
As per CALOT trial data, this patient should have a chemotherapy for at least 6 cycles. And then after chemotherapy, I will test her for FSH and estradiol. If she is postmenopausal due to chemotherapy-induced amenorrhea, we can go for aromatase inhibitor, or otherwise I will go for ovarian suppression followed by aromatase inhibitor.
I will stop you here. I don't think a 36-year-old who's got amenorrhea because of tamoxifen becomes postmenopausal. She's only got a suppressed ovarian function. You will have to suppress it by either GnRH analogs or an oophorectomy. Either of the two will have to be done. Radiation castration does not have 100% effect sometimes, so you may not opt for that in this particular patient. Secondly, she has an ER positive recurrence in a patient on tamoxifen who's ER/PR positive earlier. So as I see it, the tamoxifen failure is much more likely in this situation. You have to go on to a second line. So GnRH with AI is a good option. Calor specifically said a systemic chemotherapy, yes. But in this situation, when she's strongly ER positive, trying out an AI with an ovarian suppression is a good alternative. But early onset or early treatment with a systemic chemotherapy does benefit in ER/PR negatives more than ER/PR positives. So in her, I think an AI with GnRH, what Sunita said, is a very good option. Can we move on to the next now?
Yes, madam. We've finished with this case. I'll move to the next one. So this is our second lady for discussion today. She is a 56-year-old postmenopausal lady. She was diagnosed with right breast cancer in February of 2020. Clinically, she had a 6 centimeter lump with no significant palpable axillary nodes. Her contralateral breast and axilla were normal. She had no comorbidities or no significant family history. Her right breast core biopsy was invasive ductal carcinoma grade 3, ER 90%, PR 80%, HER2 negative. Right axillary node FNAC was reactive. She underwent an appropriate workup, following which she underwent right mastectomy with sentinel node biopsy. The final histopathology was a 5.5 centimeter invasive ductal carcinoma grade 3. DCIS was noted, LVI was absent. Her sentinel nodes were negative. She proceeded to complete her adjuvant chemotherapy and radiation. She completed it in October 2020 and was then started on letrozole.
All right, hold it. Few points in this. So this is a patient who is 3 years back, 2020 February, has had her surgery. She's a postmenopausal lady. Anything in her basic primary treatment and history that you think would put her at a higher risk for a relapse? We know that we're discussing recurrent breast cancer. Hence, I'm asking. Otherwise, if you look at it, this is a patient who's got what risk factors in her for a local recurrence?
Dr. Radha, do you want to take that question?
From histopathology report, margin status.
She's had a mastectomy. Is your margin status in mastectomy that important?
She underwent a mastectomy with sentinel node biopsy. She had a 6 centimeter tumor, underwent a mastectomy with sentinel node biopsy.
Any other high risk factors in this that you see, which puts her at a higher risk for a relapse?
Grade 3 cancer.
Grade 3, all right. What else?
T3 tumor, primary.
T3 tumor, very good. So 2 important things that we see here, and none of things really stand out as an important reason for her to have a relapse. But I would say, hold on, there is something else. What else is there? Sunita, can you pick that third point? She's a T3 tumor. You can identify it, say no quick.
Dr. Sunita, anything that you're able to notice?
DCIS, ma'am.
As already discussed, DCIS has no significance for local recurrence unless and until it's margin in the Masterclass disease. So we are not interested in DCIS here. LVI is absolutely a node negative patient, so her risk is low. Had there been positive, you would have, but this risk is if she doesn't get her chemotherapy. She's also received her adjuvant chemo. What is important here is she had a sentinel node biopsy for a T3 tumor. The indications for sentinel node biopsies are not for T3 tumors. They've expanded their own in clinical practice, doing it just because it's palpable. In her situation, I don't know how many nodes were picked in this. That is not there in the histopathology report. The sentinel node biopsy she underwent, but I don't know whether it was 0 out of 1 node, 0 out of 2 nodes, or 0 out of 5 nodes. That has to be an information that we need to know. Because if it was 0 out of 2 nodes in a 5.5 centimeter tumor, I would still be wary that we may have missed the actual sentinel. So possibility of her having an axillary relapse is also higher in a T3 tumor, grade 3 T3 tumor. But we know covered with systemic chemotherapy, which may partially study that was there, that when there is systemic disease in the axilla, chemotherapy can also act as a protective factor there. All right, let's move to the next.
So in February of this year, that was 2 years and 4 months after she completed her radiation, she presented with a palpable axillary lump. On examination, she was found to have multiple matted right axillary nodes. Her right chest wall, left breast, and axilla were normal. So on the left is a picture of the ultrasound of her axilla. Dr. Sunita, can you tell us what are the characteristics of a metastatic node on an ultrasound? How would it appear on an ultrasound?
Oval in shape with loss of fatty ileum and taller than wider. And hypoechoic lesion.
All right. So you can see that in the history now, what we had discussed in the previous slide, what was going amiss was probably doing a sentinel node biopsy in a patient who had a T3 tumor. And she's now come back with disease in the axilla. All right. So the indications for doing sentinel node biopsy should always be selective, and you have to keep that in mind when you offer it to a patient. Now, in this particular one, as you can see, ultrasound has picked up. That looks to be a very smooth oval lump there. I don't see any of the features that you have described, excepting, of course, there is no fatty hilum there. That's probably the only feature. Was there a tissue diagnosis done on this?
Yes, ma'am.
But she has matted axillary lymph nodes, so obviously that goes in favor of a disease, even if I don't get an ultrasound or an FNA on her.
She underwent breast imaging, so her ultrasound picked up multiple enlarged axillary nodes, largest 2.5 centimeters. The right chest wall, left breast and axilla were normal. Her routine blood investigations were normal. She underwent an image-guided core biopsy of the axillary node that came to be invasive carcinoma grade 2, ER 20%, PR 10%, HER2 negative. She underwent a PET CT for metastatic workup that picked up multiple hypermetabolic enlarged left axillary nodes suggestive of metastasis. I think that should have been right. Hypermetabolic lytic lesion with sclerotic rim in the neck of the right femur. So the SUV for the nodes was 13 and the SUV for the femur lesion was 8. There was no other active disease elsewhere in the PET CT.
All right, we'll stop here. So tell me, Radha, what is it that you're finding here different, and what is important in this particular slide which suggests on the recurrent disease?
Firstly, there is axillary lymph node is positive in biopsy, but the ERPR status has changed from 90% to 20%.
All right.
And there is single bony mates in the tumor.
And a solid, right. You also see that the grade has been reported as lower. Do you think that has any implication? The answer is that you got a core biopsy which picked up a grade 2. The tumor, there is always heterogeneity. The tissue picked up is small, hence you're getting a grade 2, but it may not be a grade 2 because looking at the ERPR and HER2, low expressions, I would expect this to be a grade 3 only. So this is not like the tumor has stepped down to a grade 2 tumor now. It is just a selection bias because you're looking at a core. So you would require much larger tissue to understand whether the grade is same. I would consider it same. In fact, grade 3 only because she's 20%, 10% and HER2 negative, more like a triple negative. The ER expression has come down definitely. All right, there is a solitary met in the neck of right femur. Sunita, can you tell me what kind of disease is this now?
Ma'am, now it has changed to metastatic recurrent breast cancer.
You want to redefine a little more on the metastatic disease?
Bony met.
Okay, something else? Solitary met, can I add that?
Yes, ma'am.
What is it called as? Is there a terminology for that, Radha?
Oligometastatic.
Right. So you have oligo-recurrent disease with a solitary met to the neck of right femur. What are her risk factors here? From her distant metastasis, what are her risks? She's a 56-year-old postmenopausal, was on letrozole. Let me just remind you. I'm sure her bone mineral density had come down. So with a neck femur disease, what is her risk?
There is risk of pathological fracture.
Right. So she has got a risk of pathological fracture. The immediate thing you will tell her is stop walking around, use a wheelchair, don't put strain on the right femur because it's neck. And it is highly possible that she may have a fracture. She's not had it yet, but she can easily have a fracture neck femur. Right? Can we move to the next slide?
Yes, ma'am.
All right. So we come to the discussions. How do we proceed? Sunita.
Ma'am, now we have to assess whether the patient is in visceral crisis or not. But since it is a bony mets, we can offer directly to
PET. You've done a PET. It said solitary met. Now, why would
solitary.
you?
But
what is a visceral crisis, Dr. Sunita?
Visceral crisis is severe organ dysfunction with changes in lab values and patient present as an emergency, depending upon the visceral site of metastasis.
See, it's good to know these terminologies, but you should also be able to apply it in clinics. This patient, who's a 56-year-old, has a solitary met in neck of the femur, which is a sclerotic area. So you don't see a reason why you would think of a visceral crisis in this particular patient. You don't expect her biochemical parameters to change, right? So that is not applicable. So what else? Move on to the next. You know the disease now, oligorecurrence. How would you manage this patient?
For bony mets, I would like to start her on bisphosphonates or bisphosphonates, and then since it is neck of femur fracture, then I would like for to undergo stabilization in the form of surgery.
Remind you of her disease condition. She has got matted axillary lymph node axilla with a recurrence, and she has a solitary met in the neck femur. Now tell me, how will you manage with this patient? Keep the whole patient in mind. Don't look at only one or two things. Whole patient in mind. Radha, your turn to answer.
Ma'am, as the patient has bony disease, I would like to start with bisphosphonate or denosumab after dental checkup, and also the endocrine therapy with change of drug.
All right, I take
And also,
again, I will remind, I'm again interrupting your answer because I don't see it going in the right path. She has stepped down on the ER/PR expression. She has ER 20%, PR 10%, HER2 negative. She's got matted axillary lymph nodes. I'm saying it the third time. And she has a solitary met in the bone, which can have a risk of fracture. Again, think again and give me an answer. What is your management here?
Chemotherapy. She should
due to
chemotherapy.
increasing risk of fracture.
Chemotherapy.
Would like to know what did she receive in the first line, because that
Line.
here. So Nisha can tell us what she received in the first line, then we can look at the second line.
She received anthracycline, madam, 6 cycles anthra in the first go, and then proceeded towards radiation and then on it.
She's received anthracyclines, you're not going to repeat it. Her cardiac status is fine, I assume. She's 56-year-old. Now, got matted axillary lymph nodes. What is the other option that you can have now?
We can give taxane-based chemotherapy.
Taxane-based, I'll accept that. You have to give a more specific answer than just saying taxane-based. Give, because she's...
Paclitaxel.
Yeah, would you give a single agent Paclitaxel?
Paclitaxel with carboplatin. Platinum.
Okay. Why can't you give a single agent Paclitaxel in her? In a metastatic condition, I'm now bringing you back to the fact that she's not a triple negative. The advantage of platinums is not really there. She's not a triple negative, but she has definitely got an underexpression of the ER and PR. Correct?
Yes, ma'am.
PR positive. All right. So you are looking at paclitaxel. Would a single agent be okay with her, or do you think she would require to have something with it?
Ma'am, as the tumor burden is high and patient has impending fear of pathological fracture, I'll give a combination chemo like docetaxel, capecitabine, or gemcitabine paclitaxel.
Though, of course, systemic treatment is not a major line of discussion here. Any other factors you would like to check in her?
BRCA testing.
BRCA test.
Sorry, I will start her with the AI and CDK4/6 inhibitors.
That is an option, yes, with an oligo, but you're looking at matted lymph nodes. So we are not again talking about, because these lymph nodes, had they been solitary lymph node palpable, I can understand we could still consider her for a hormonal therapy with a CDK4/6 inhibitor, but we are not talking about matted axillary lymph nodes in a recurrent situation within 3 years and an underexpression of the ER and PM. So anyway, you would look at a combination chemotherapy and followed by maintenance on an AI with a
Maintenance on AI and CDK4/6 inhibitor.
Yeah, that could be a possible option after completing the treatment. What other option is there? What other management that you have to look at? Primarily, solitary met bone. Would you offer radiation now or would you offer radiation after the chemo?
If the patient is symptomatic, there is pain, I will offer radiation now. But otherwise, if the patient is asymptomatic, I will just keep on
Symptom.
denosumab, bisphosphonate, calcium, and vitamin D.
What is the symptom you're waiting for in a neck, in the femur neck? Pain or fracture?
Pain.
So would you wait for the symptom or would you do a prophylactic radiation for her because she's a high risk of fracture in the neck? You would?
Is
do
this? Yeah.
This patient would need a prophylactic radiation irrespective of symptoms because it's an axial skeleton, it's weight-bearing bone, and she needs to be prevented from fracture. That's why I said we will put her on a wheelchair, tell her not to walk. The reason why I gave that indication was because you know that it is an emergency to treat a neck metastasis. That's a high risk for fracture. You don't want the patient to be bedridden with a fracture. You're planning her for a chemotherapy, you want her ambulatory. Okay. All right. Anything else on this? What was done for patients? Can we know?
Yes, madam. The first case, she was discussed in our tumor board. She expressed a keen interest in having a reconservation. So she underwent a redo BCS with a redo sentinel, followed by tumor boost to the BCS area. And then she was put on letrozole, followed with the ovarian suppression. The second lady underwent taxane-based chemotherapy. Following that, she was discussed in our tumor board again. She underwent an axillary clearance. And she underwent, she was symptomatic for the femur, so she underwent radiation for that site.
All right. So the second patient is fine. That's exactly what you would do after response to chemo. She would have a clearance and of course a radiation to the bone. But the first patient, you said she had letrozole and GnRH. It should have been actually GnRH started, waited for 2 weeks, and then start the AI because you want the ovary to be fully suppressed. You don't want to start them together. In such a situation, in recurrent situation, if you're considering hormone therapy, you have to do GnRH first, and 2 weeks later, you will start with AIs. She's a premenopause in that sequence.
Yes, yes, madam. I think that's what we did.
Conservation, as I've said, evidence is lacking, but you have to do this only after a discussion, counseling of the patient that she still stands to be at risk for a relapse again. If she's accepting all of those, you can offer it, but it's not the standard of care to do a post completely irradiated. Remember, she's received boost NAC when she's had surgery. Now you're giving an additional little bit of radiation in that area to it. It's like a second boost. There is not much of an evidence. The complications rate may be more. There'll be more fibrosis, and the risk will still remain high for her to relapse again. So
Agreed.
that's the standard of care. But yeah, if the patient wishes, you have to explain and then do this.
Agreed, madam. As far as, from the exam point of view, completion mastectomy for any local recurrence and axillary clearance, if there's any recurrence in the axilla or in cases of IBTR, is the standard of care. What we did was more real world and in discussion with the patient and with the tumor board and everything else. But it's not something you would say in an exam upfront right away.
Right. Anything else after this? So we have any more?
No, with that brings us to the end of the discussion. It was a lovely discussion. Both Dr. Sunita and Dr. Radha, both of you did very well. And we enjoyed the discussion a lot, madam. So I'll hand over to Srajan if you're there.
Thank you, Radha and Sunita. You did a good job. But yes, some more reading required. I'm sure you will be ready for your exams very soon.
Thank you.
Thank you, the examiners and examinees, for this wonderful mock roundup. We'll now move on to the second part of the webinar, which would be the expert talk by Dr. Vani Parmar. Madam, you may load your screen, and we are all yours. In the meanwhile, I'll request Dr. Hariharan to kindly go through the Q&A box. There are multiple questions there, so you can answer them, and I'll select a few for Q&A, which follows Dr. Parmar's talk. The screen is visible, madam, not full screen yet. And you're muted.
Yeah, I'm still not full screen.
It's not full screen, madam. Can you just stop share and share the screen instead of just the PowerPoint?
Share the screen. Okay. Is that now okay?
Perfect, madam.
I do hope this works, because there was a time when I had a little issue with my Zoom where it was not working. So let's hope this works this time. All right, so we've had quite a bit of lively discussions with both the students on the contemporary management and what is the standard of care, and when you're talking about recurrent breast carcinomas. So let's look at what does the evidence say and what is the important points. It'll be, some of these will be a repeat of what we have just said, we have discussed, but so that will help me to actually go through it much faster. Well, my screen is not moving. Yes. So is the screen moving with you?
Yes, it is.
All right, perfect. So like we discussed in both these cases, in fact, we got most of the answers there. Who are the patients who are at risk for recurrence? So when we look at any histopathology report and we are planning a treatment, we should be able to pick these points in any patient who's just finished her adjuvant therapy as to who are the patients who are at risk for recurrence. So any patient who has a high nodal positivity, as we know, lymph node positivity is the most important primary factor, which comes in as far as the prognostic factors are concerned. So high nodal positivity in a primary surgery should alert us that this patient may be at high risk for relapse, whether local regional or distant. In majority of the cases, it is distant recurrence that they are at risk for. Poorer biology, as we have seen, triple negative breast cancers and HER2 positive. However, both the cases we discussed today were ERPR positive, HER2 negative. But these are the patients, triple negatives and HER2 positives, who are at high risk, and HER2 positives, especially so if they have not received an anti-HER2 therapy in the first line treatment. Higher stage of disease, locally advanced or a large operable, margins being positive or unknown, especially so if they are EIC positive. Re-excisions done, that means the patient had an incomplete surgery elsewhere and you have now offered a treatment of re-excision in the form of either a BCS, whether it is post-chemo or a mastectomy. Such patients are relatively at a higher risk for a relapse. Presence of lymphovascular emboli or lymphovascular invasion. These are the patients who would be at risk both for local recurrence as well as for a distant recurrence. Young age and post-chemotherapy poor responders. These are the patients who have large tumors still and they would be at a higher risk. So offering conservation in them would also not be advisable because they would be at a higher risk. If there is evidence to say that there is a higher rate of relapse post-chemotherapy, again, these are the patients who don't have a complete excision. Even a complete response patient, when you're doing a tumor bed excision, if it's not properly marked, you may leave behind tumor cells and there is a higher risk for relapse. An inadequate primary adjuvant in the form of either patient having missed radiation, local regional radiotherapy, or inadequate systemic therapy can have a resultant risk for relapse. We did see a few other things in the two cases that we discussed. Like, for example, the second case where we had a large operable disease and we have decided to offer them a sentinel node biopsy. These are not the routine for such patients. The risk for relapse in the axilla then becomes much higher. Now, understanding what is recurrent breast cancer and metastatic breast cancer. When we're talking of recurrent breast cancer, it encompasses a whole lot of recurrence. It could be a local, isolated, local regional recurrence, or it could be even distant, or as we call as a metastatic breast cancer. But the timing of metastatic breast cancer redefines it into a de novo and recurrent. So de novo are those who have an intact primary, untreated, and recurrent breast cancers are those who have had a primary treatment and have now recurred. When you look at outcomes, the de novo metastatic breast cancer is actually treatment naive and relatively do better as compared to those who have failed on treatment or are called as recurrent cancers, who have a poorer outcome. What is the incidence? Locoregional recurrence is about 3% post-breast conservation, as we heard previously from our students as well, but it may be higher post-mastectomy. But when there is a locoregional recurrence, there is a 9 to 25% chance of having a distant disease. Those who recur while on treatment, these are those who are receiving the primary treatment and have a recurrence during treatment, behave worse as compared to those who recur after a period of time. And that's where the primary resistance and secondary resistance comes in when you talk about hormonal therapies. Outcome obviously is impacted by the tumor burden as well as biology. And in the amount of recurrence, that is oligorecurrence versus extensive. And recurrence biology, that means the tumor expressing ER/PR and HER2, impacts prognosis. We don't really talk too much about Ki67 in a recurrent situation, but ER/PR and HER2 itself defines the prognosis in these patients. When we define a recurrent breast cancer, we describe a recurrent breast cancer, there are a few things we have to keep in mind, whether they are symptomatic or asymptomatic. Now, the minute you talk about a symptomatic recurrent breast cancer, this could be in the form of a disease that's palpable, but many times you find that the patients are undergoing repeated screening in their follow-up, and disease which is asymptomatic is picked up. So asymptomatic recurrence is actually something that's been picked up before the development of symptoms. And there is actually a time shift that is happening. So it's not that these do better, it's just because they have been picked up before they got symptomatic, but the outcomes remain the same, as we know in the intensive follow-up studies that have been done. Again, post-primary treatment, complete or incomplete. Those who finish their primary treatment complete and then have recurred versus those who did not complete and recurred, there is a difference in the two. Whether they progressed while on adjuvant treatment, DFI is an important factor, whether the recurrence was early within a year's time or it was beyond a year's time, locoregional or distant or both, hormone responsive, HER2 expressing, and of course, other markers that influence treatment, that is PD-L1, germline BRCA mutation, CDK4/6, PIK3CA, and PALB2. All of these help us to influence the systemic treatment of disease. What is treatment in recurrent breast cancer driven by? And as I warned you earlier, there's a lot of repetitiveness in what I'm talking, because remember, these have impact on every step on diagnosis and management. So DFI, less than or more than 1 year, tumor biology, previous treatments taken or completed, what was the toxicity to the previous treatment, what are the age and comorbidities, and of course, affordability and cost-benefit ratio. Whatever you do to a patient, you have to have a shared decision-making when it comes to the patient being planned for further treatment. And not to forget, quality of life is the most important factor which you have to keep in mind when you're treating a recurrent breast cancer. What are the principles of management? Again, it is defined by the extent of disease. It is also influenced by what was the primary treatment given. The intent remains palliative whenever there is a recurrence. But when it comes to oligorecurrence or limited disease, you may actually adopt an aggressive approach, because here the intent changes. It is not palliation. You are trying to control the disease completely. And oligorecurrence is something that redefines disease as those which have better outcome. Hence, it is a limited disease recurrence. It is always a multidisciplinary treatment planning, and systemic treatment should be preferably offered first. Exceptions may be where there is a small resectable oligorecurrence and you may want to have the surgery first. In such situations like isolated locoregional disease, or surgeon's role is also seen where there is a palliative surgery because of bleeding or ulceration in the disease. But in all aspects, I would say a systemic treatment is what you would offer first in any relapse situation. Goal is, of course, palliation. But remember that improving overall survival is the goal in both metastatic and recurrent breast cancer. It may not be possible in certain situations, but whatever treatment you are offering has to be also symptom-related intervention. So quality of life is very important, maintaining good quality of life, and whatever treatment you offer cannot have a negative impact on quality of life. Steps in establishing diagnosis, we have already gone through them. A detailed medical history, clinical examination, imaging, as we have already discussed, hematology, biochemistry. A rebiopsy is important because you're looking at the change in biology of a tumor. What change in biology can you expect? Tumor type? Tumor type would possibly change if it is a new primary. But in majority of cases, when there is a recurrence, the tumor type remains the same. However, ER and PR, loss of hormone receptor expression in recurrence, implies that the hormone treatment is effective in suppressing the ER/PR positive disease and implies a clonal selection. HER2 expression again can be variable between primary and recurrence. But the importance of knowing the tumor biology of the primary and the recurrence, there is an important factor here, is what do you do regarding the systemic treatment? Do you treat based on the primary or do you treat based on the clonal selection? Of course, there can be various controversial discussions on this, but the use of endocrine therapy or anti-HER2 therapy should be considered whenever ER or PR or HER2 are positive in at least one biopsy, regardless of timing, baseline, or recurrence. The IASO guidelines, however, beg to differ slightly here because they did say that change your treatment based upon the recurrence. But remember that logically speaking, if there is an ER/PR positive tumor and now the patient has come back with a relapse which is ER/PR negative, it implies that you need to add chemotherapy to the treatment, but you would not stop the patient on hormonal therapy hereafter because it is the prevention of recurrence of ER/PR positive disease that the hormonal therapy has effectively shown. So you would put the patient back on hormone therapy once the chemotherapy is over. Similarly, HER2 positivity at any point of time would imply that you would continue with the anti-HER2 therapy later. What about tumor markers? The role of tumor markers is very controversial. It may only be used to monitor a treatment response when it has no other implication. And would you do a systematic brain imaging in HER2 positives? Not really, not recommended, as they do not really pick up disease in these patients. Coming to specific situations, management of isolated locoregional recurrence post breast conservation or mastectomy. Now, in case of unresectable recurrent disease, if you have a disease which is unresectable, as we saw in the second case where there was matted axillary lymph node, you will require an induction chemotherapy irrespective of the hormone receptor status. And in that patient, I will recall again, was an ER/PR expression gone down, 20% and 10% HER2 negative, but matted lymph nodes, you would have to consider her for a chemotherapy first. You may put them back on maintenance hormonal therapy later. Surgical extent, if feasible, is based on the prior surgical intervention. So if she's had a breast conservation earlier, you would now offer her a mastectomy. If she had a mastectomy earlier, you would do a wider excision of the local recurrence. It might be with SOS flap. If the disease is resectable upfront, then a surgery followed by early systemic therapy as evidence shown in the CALOT trial. The reference has been given below for your reference. We've already discussed this. If there's a patient who's had a breast conservation with radiation given to the whole breast, the treatment ideally would be a total mastectomy with axillary clearance if the previous was a sentinel node biopsy or a low axillary sampling. A re-sentinel node biopsy, there is no convincing evidence. The level of certainty is low and grade is C. Isolated locoregional recurrence in select cases with a long disease-free interval, low-grade disease, no familial history, previous partial radiation may be considered for a re-BCS with axillary clearance plus a re-radiation. Post-mastectomy, obviously you've already had a breast removed. If not radiated, once you do a recurrence excision, you will require to do a radiation for that. Now, the remastectomy will be a radical. If you have done a modified radical earlier, it will be now a radical mastectomy with SOS flap cover. A small isolated locoregional recurrence with a long disease-free interval, previously completely radiated, you may consider for a wide excision plus a recurrence-bred brachytherapy. So that's an exception here when there is a small recurrence in a patient who is of a low-risk disease. But if there's a recent mastectomy with radiation and now has a locoregional recurrence, a radical mastectomy with SOS flap cover and no re-radiation will be the standard. How do you treat a regional or locoregional recurrence? An axillary recurrence, axillary clearance after induction chemotherapy, no radiation to axilla. If supraclavicular or internal mammary recurrence, you do a systemic chemotherapy followed by surgical clearance in supraclavicular fossa. And radiation to be considered if RT naive from previous treatment. That means if she has not received a radiation previously, you would now re-radiate. If patient has received a supraclav radiation, say for a locally advanced or a large operable breast cancer, has comes back with a supraclav recurrence as seen in 15% of cases, you would do chemotherapy. You may consider surgery, but there will be no re-radiation to the supraclav. Specific central nervous system and bone metastasis. Commonly, they are triple negatives or HER2 positive disease that go to the central nervous system, in the sense to the brain or to the spinal cord. Bone metastasis in such situations would be to the calvarium, which can happen in ER positive disease. So ER positive specifically go to bone. Exceptionally, triple negatives can spread to the marrow, especially the flat bone, and this will be marrow metastasis. And they would be treated as a visceral metastasis. And when there's extensive involvement, it can also cause a visceral crisis. The treatment would be as a standard, radiation to the affected part, bisphosphonates to be added, and systemic therapy to be planned. Coming now to the planning of systemic therapy, it is always based on biology. It is based on what was the first line therapy and what was the response to it, whether or not patient had completed the first line therapy, and what is the current disease burden, whether there is a visceral crisis or not. In ER positives, you may prefer second line also as an endocrine therapy if there is no visceral crisis or life-threatening disease. In ER negatives, you would still prefer a chemotherapy and, of course, continue the targeted treatment in HER2 positives, and the options are many now. I'm not going to go into too much of details in the systemic therapy planning, but just a brief overview. Endocrine resistance, we have discussed this before. What is the primary endocrine resistance? When it is relapsed within 2 years of starting endocrine therapy, or if there is progressive disease within 6 months of starting first-line endocrine therapy for advanced breast cancer. Secondary would be relapse on endocrine therapy after 2 years of treatment, or a progressive disease after 6 months, more than or equal to 6 months after starting endocrine therapy for advanced breast cancer. Presence of visceral disease alone on relapse is not a contraindication for using endocrine therapy as second-line therapy. This holds true if the visceral disease is limited disease. Even in a patient who's received, say, letrozole as a first line of therapy, presence of 3 to 4 liver metastasis does not warrant the patient to start on chemotherapy. You can still consider in such patients endocrine therapy along with the additional therapy as we have discussed further. So a luminal A tumor, sequencing endocrine therapy in a luminal A. In pre or perimenopausal women with ovarian function ablation and an AI, or treat as postmenopausal after oophorectomy. So you can either offer a oophorectomy, surgical or radiation, and consider for AI. If you're considering them for GnRH analogs, ovarian ablation, please wait for 2 weeks for the suppression of the ovary before starting aromatase inhibitors. Otherwise, it can actually stimulate the ovaries. In postmenopausal women after AI, options can be tamoxifen, restarting, or even offering tamoxifen, fulvestrant, AI fulvestrant combination with CDK4/6 inhibitors, or endocrine therapy plus mTOR inhibitors. In second-line treatment for men, GnRH analogs with aromatase inhibitors can be offered after tamoxifen. And there's not much evidence for concurrent endocrine therapy plus chemo. As far as the postmenopausal women are concerned, there is some evidence that you can actually combine chemotherapy with endocrine therapy without harm to the patient. And these are where you're looking at a single agent chemo. One could possibly consider even starting off the hormonal therapy with chemotherapy. So dual therapies are known in postmenopausal patients. As far as targeted therapy is concerned in advanced breast cancer, fulvestrant plus AI, CDK4/6 inhibitors we have already discussed. The evidence I have listed here. You can use palbociclib, ribociclib, or abemaciclib. mTOR inhibitors, everolimus, as shown in Bolero 2, and PARP inhibitors, olaparib and talazoparib. Targeted therapy in HER2-positive advanced breast cancers. First line, again, a dual inhibition, trastuzumab with pertuzumab, or along with taxanes, or trastuzumab, capecitabine with or without pertuzumab, or use of TDM1. Second line would be TDM1, which has been shown to be better than lapatinib and capecitabine. Third line treatment, again TDM1 or lapatinib with capecitabine for an oral combination, or trastuzumab with chemo. In triple positive metastatic breast cancer, endocrine therapy with trastuzumab or lapatinib can also be considered. As I've said, I'm not getting into too much details in treatment, in systemic treatment of breast cancers, metastatic breast cancer. In triple negatives, the first lines can be in the advanced situation or recurrent situation, anthracycline plus taxanes if they have not received earlier, vinorelbine or capecitabine, bevacizumab with taxane capecitabine, carboplatin and gemcitabine. In germline BRCA mutated tumors, carboplatin single agent, same effect as docetaxel. And of course, atezolizumab with nab-paclitaxel in PD-L1 expressing tumors. So knowing the tumor expression of various factors, especially PD-L1, can also help you decide on the systemic treatment. Second line can be a single agent of the listed drugs. When it comes to luminal advanced breast cancers, again, limited first line, anthra plus taxanes, nab-paclitaxel weekly or 3 weekly, bevacizumab plus taxane, or vinorelbine and capecitabine. And second line would be single agent drugs. I've just listed here certain guidelines, which I think is very important to read to understand the management of advanced breast cancer. These are the COM clinical guidelines, the ESMO clinical practice guidelines for diagnosis and treatment of patients with metastatic breast cancer in Annals of Oncology, and the NCCN guidelines, version 3, 2020, which has been brought out, which is again a very comprehensive guide to treatment of metastatic and recurrent breast cancers. Thank you very much. If there are any questions that have come up, I would be happy to answer them.
Thank you, ma'am, for that comprehensive talk. We move on to our third section for the day, which would be the Q&A. I request Dr. Hariharan also to come online. I've chosen the few questions which seem relevant and I've kind of grouped them. So can I request Dr. Hariharan to kindly go through the questions and take Madam also? I have just put the names for a starting point. Obviously, both the comments of both examiners are invited.
Okay, Rajan, if I can, we'll just take one question from Dr. Chandramohan first. That's in the panelist section.
Yeah, I've included that in the third question.
All right. So, Madam, the question from Dr. Chandramohan is, do you use NGS to differentiate recurrence from second primary?
Well, to be very frank, I have personally not used that. I mean, we can use various other factors, clinical factors only, which will give you a suggestion of a new primary versus second primary. Either ways, if you understand that the management is not going to majorly differ. Now let's look at it. Why am I saying that? So if you have a tumor which is grade wise, a lower grade than the primary, right? That could imply that this is a new primary. If there is DCI present in the recurrence, it could imply a second primary again, right? So these are certain things. Biology, if the biology differs from the primary completely, like you had a ERPR positive, HER2 negative in the first situation, now you have a ERPR negative, HER2 positive in the recurrent situation. Again, it suggests that it is a second primary. I would probably not move to NGS to find out whether or not, this is a different disease. Why is that so? Because your whole management is based upon where is this tumor situated. Is it very close to the tumor bed or in the other quadrant? If it's in the other quadrant, there is no way that I would be offering her a conservation, because you have to counsel the fact that patient that if she's at risk for a second primary in her breast, then saving the breast further when you cannot re-radiate it completely is again an unadvisable management. You would discuss these options with the patient, and you have to have a proper discussion, because patient just wanting to save the breast may not be the only reason as why you would offer. It's even better to do a mastectomy with a whole breast reconstruction in that situation. So an NGS would not really take me forward to, that would not be one of the tests that I would ask for, because I know that the implication of management is not going to be based on what NGS is telling me. There are a lot many other factors which are more important. Hence, I would not ask for an NGS.
Okay, madam. In continuation to this question, there's another question which is asking for, does it matter whether it is a recurrence or a new primary as far as treatment is concerned? So does it impact treatment in any way, this distinction between IBTR and a new primary?
Well, again, this is not a short answer. Because if you look at it, if the recurrence is in a different quadrant and the recurrence turns out to be a second primary, it's a new primary, and patient is very keen on conservation, if she's had a long disease-free period from the previous surgery to the current one, I would still probably think of even doing a wide excision and do a radiation to that, as long as she'd not received the whole breast radiation. Any recurrence that comes up or a new primary that comes up in a radiated breast is itself a poor prognosis. It is like saying that in-field recurrence. It is an in-field new primary, in-field recurrence. Any of these would behave badly, and you have to go back and look at her genetic evaluation again, because obviously we have missed something. That is why she's come back with a second primary in a radiated breast.
Okay, madam. And if we have a patient who's had a mastectomy done and come back to us with an isolated sternal metastasis, so would we consider them to be a local recurrence and treat them in that fashion?
Not really. They are oligorecurrence in the bone, sternal recurrences, unless it's an internal mammary node which is kind of invading or eroding into the sternum. That's another possibility. You would give them a definitive treatment because it's a limited disease again. So wherever you have oligometastatic, whether it is sternal, whether it's a single rib, whether it is just one site in the femur, any of these would be a consideration for doing a definitive treatment, because the outcomes in these patients would still be better as compared to an extensive disease. But remember that they would fail sooner or later, but you would go ahead and treat this. So sternal resection can be an option. As in case of the neck femur, one could have considered even a complete resection and a replacement of the head and neck. So you can do a prosthetic implant there, but with radiation. So you would consider a definitive treatment for that limited disease, depending upon the site of disease.
Okay, madam. And there's a question regarding the real-world application for PET-CT. So NCCN routinely recommends CCT thorax abdomen and not PET-CT for metastatic workup. So how do we tackle this difference?
Well, to be very frank, the role of PET-CT, NCCN guidelines, obviously you're talking about the 2020 now. I think the last 3 years during COVID, we've also zeroed down to doing tests which are more limited and not sending the patient to multiple places. So when it is a recurrent disease, you want a test that is more sensitive to be able to pick up, because you want to be sure you are treating limited disease or extensive disease. This is in complete contrast to locally advanced, where the incidence of picking up a multiple site disease is much lower as compared to a disease which is already presented itself as a recurrence. In recurrence, the use of PET-CT, I would put it at the same level as doing a CECT and bone scan. So I think it kind of makes it more simpler if you just do a single test in this situation. And PET-CECT can be done in these patients, and other guidelines do not recommend a PET-CT. So I think we are okay individualizing the patient. And if you have the facility available, go ahead with the PET-CECT, especially in a distant disease patient, in a recurrent situation.
Our next question is, does a previous SLNB distort the lymphatic pathway? And how would that affect our treatment?
It would, because you are disconnecting the breast drainage, irrespective whether you're doing a sentinel node or you're doing a low axillary sampling. Because you've already taken the first lymph node, first echelon node has been removed, along with it the adjacent node. So you have already broken the pathway when you've taken out the sentinel node. Now you would expect a new sentinel node to now develop because there is pathways which are going to deviate out, right? The point is that if the patient has had a breast conservation, has had a relapse post-radiation, there would be fibrosis in the breast, there would be fibrosis to some extent even in the breast lymphatics. So the drainage pathways are not going to behave in the normal routine manner as you would expect in the upfront situation. Of course, if the patient had an APBI and limited radiation, you may still consider a resentinel node in such situation. But I would discuss this with the patient, and if the patient has got other factors which are unsuitable, has lymphovascular emboli, I don't think a sentinel node here is going to really help me because I know there is already emboli and there is involvement of the lymphatics as well. So having a lymph node as a skip metastasis is much higher in this situation. So if your core is already picking up LVE, I think it's better that we don't consider these patients for a resentinel node biopsy.
Okay, well, the next question is, when we do a genetic workup for patients with breast cancer, should we only use BRCA or should we use a wider panel that also involves P53 and other markers?
Yeah, I think a detailed clinical history is much more important. Understanding if the family history had any other kind of cancer also. Because we kind of focus only on BRCA, and BRCA alone is not your answer because there can be other risk factors. Because if there is a prostate cancer in the family or a gastric cancer, you need to know other members of the family, and the family tree as far as the cancer distribution is concerned is very important. So testing for others, including P53, is also important to know whether these patients have, say, variants of unknown significance as well. And in such situations also, you would want to counsel the patient before you decide on doing a reconservation in such situations.
Our next question is, how do we decide what is an adequate DFI to decide recurrence and to proceed with treatment that would focus towards complete removal of the tumor? How does DFI impact our management?
See, as far as a disease-free interval of less than a year, this patient is slowly failing on treatment and has some high-risk features. That is the reason why the relapse has happened. So the definition takes into consideration 1 year as your cutoff for deciding whether you want to consider for a re-challenge with an endocrine therapy or you want to consider for a systemic chemo now, because the patient has failed within a year's time. It also defines your endocrine resistance. But if you look at the actual definition of endocrine resistance, it goes beyond a year. It goes even up to about 2 years. So the minute you have a patient who's, say, in a low-grade disease, has relapsed within 2 years in endocrine sensitive disease, you would call them as a primary resistance to the endocrine therapy. But if a patient has responded in spite of other high-risk features, has remained disease-free for, say, 4 years, you have a longer period which suggests the patient is still sensitive to hormone therapy, but has now developed a secondary resistance. So if there is a secondary resistance, then you would treat according to that. And you have to do a value judgment on the extent of disease, the disease-free period, the primary response and toxicities, and the site of metastasis before you decide. Of course, the biology being the main crux here, to decide what should be your next line of treatment.
Okay, madam. I have one question for you, madam. In our first case, the young girl with the 36-year-old girl who came back with the small recurrence in the breast, had she been BRCA positive, had she come out to be BRCA positive, say BRCA1 or so, how would we have, or how do you think we should have managed her when she came back with the recurrence, assuming she opted for conservation previously? How would we have proceeded with her treatment?
Right. So if you see, her first disease was a low-risk disease. She had a grade 2 tumor, highly endocrine sensitive, HER2 negative, more of a, I would say, a BRCA2 kind of a disease rather than a BRCA1. She had a family history. Mother had breast cancer at the age of 65, right?
Yes, madam, 65.
She has a family history of breast cancer, and she is about a disease which is low risk. Now, in this situation, there are two options. One is she has already developed a disease, but which is not a high risk. She is on endocrine therapy, and the endocrine therapy works on both the breasts. It's not just the ipsilateral disease, would also prevent recurrences, reduce recurrences by 50% on the contralateral side. So there is a protection that you're offering by giving endocrine therapy to her as the treatment for primary and a prophylactic for the contralateral. You have to counsel the patient. The counseling here would imply that you have to explain to the patient she may be at high risk for not just for breast, but also ovarian disease. She can opt, if she has completed her family, to have a bilateral prophylactic oophorectomy. If she has a prophylactic salpingo oophorectomy, she will be protected, of course, for ovarian cancer. At the same time, she'll have protection for breast as well, and she continues her hormonal therapy. But if she is of the type who is extremely anxious and is not a good candidate for surveillance or has got social issues, you might counsel her in that situation to have a bilateral prophylactic mastectomy. But it has to be at the end of a long discussion, which explains to her the risks involved, the benefits involved, and what is expected of her. So even a young patient, say if she was 36 but did not have a child, has not, not completed family, wishes to have a child, you would not tell her not to have a pregnancy just because she is BRCA2. You will counsel her if she is willing to go ahead with good surveillance. You may delay the salpingo oophorectomy till she's had a child, but remember, she's ERPR positive, she will be on hormone therapy. So it's not an easy decision here because there are multiple factors. She would be on 5 years of tamoxifen. That's when you would give her a break. She's already 36, she'll be 41. Chances of conceiving will be less. Would you ask for then an oocyte preservation or any of those? But at this age, and if she's not conceived so far, her chances that she'll conceive later is going to be even less. And you need to know her primary infertility reason for not having conceived till 36. So there are multiple factors that fall in. So you have to know all of these factors, and that's what genetic counseling actually takes into consideration. Her age, her need for family, her level of anxiety, the surveillance, whether she's going to comply with it, and whether all of these are acceptable to her. If not, bilateral prophylactic mastectomy with a bilateral salpingo oophorectomy may be a better option for her.
Agreed, madam. In recurrent breast cancer, often the various factors that come in is what makes identifying or picking a choice of treatment a little difficult. One more question, madam. In the second case, the second lady that we had, instead of multiple matted nodes, if we had smaller nodes that were positive and that were amenable to upfront surgery, amenable to upfront axillary clearance, would you have considered axillary clearance with radiation to the femur, followed by some kind of hormonal therapy as a possible treatment option? Is it possible to omit chemotherapy for her had it been that way?
Yes, which is what I said, that if there's a limited disease in a strong ERPR positive, you may consider. But remember that in her, she had stepped down from being an extremely hormone-sensitive tumor to a low expression of ER and PR. So that was one suggestion indicating that there was a clonal selection here. So omitting chemotherapy in her may not be a very good idea because you may then, and she already had an oligomet in the femur. She had systemic disease already. She may not have expressed itself in liver or other sites. She had it in the femur, but omitting may be a little bit of a concern. But again, she is a 3-year disease-free period, 2020 operated. She's an endocrine sensitive disease. One can consider concurrent, say, acetylcholine-4/6 inhibitor to be used, or you have other tests that you can look at the expression and then decide whether she needs an mTOR. But all of these will have toxicity. So you have to also look at her quality of life and see the toxicity that she would have with chemo versus any of these additional treatment, targeted treatment to be given. If she's able to tolerate, you can consider them. And upfront surgery is an option that you do axillary clearance because the disease is anyway resectable right now. She doesn't have any other site other than the femur, and femur can be then treated either in the form of a hip replacement or it could be radiation alone, either of these. So one can consider, if resectable, for both sides, upfront surgery followed by systemic therapy. But it has to be discussed in advance with the patient, and you have to monitor the patient for the kind of response and toxicity and tolerance that they have.
Thank you, madam. That was a very comprehensive answer. I think I've covered everything that came up in the chat box. Srajan, did I miss anything?
Yeah, so one is the role of fluoroestradiol PET-CT, FES PET-CT, any real-world indications. And I think the other one is the absolute survival benefit of chemotherapy, I think in the first case which was being discussed.
I think the chemotherapy one, madam, covered in her talk. Madam, the other one, the FES PET-CT, do you think there might be any indication?
Yeah, fluoroestradiol PET-CT will give you an indication whether the recurrence that you have picked up in the bone is also ERP positive or not. So it would definitely give you a good indication of the hormone receptor expression without doing a biopsy of the bone. So it would be good, and you would be able to probably use this in the future for even therapeutic indications. But yeah, currently, as far as I am aware of it, the role of it is more to get the evaluation of the distant disease on their expression of ER and PR. If anybody else in the has any opinion on these points, yeah, I think it'll be nice discussion if they're able to communicate here. Dr. Chandramohan or.
Thank you. Nothing.
So I think that's it from the Q&A part. I'd like to thank both Dr. Hariharan and Dr. Parmar for giving us their time, preparing in detail for all our examinees and the audience, the slide set. I request Dr. Chandramohan, our secretary, to deliver his concluding remarks for the session today.
So, hello everybody. Am I audible?
Yeah.
Yeah. I think if breast oncology is a kingdom, and Vani Parmar is a crowned king for last 3 decades, and I've been listening to her for last so many years, and she never disappointed us because every presentation is a new one with a lot of new concepts, and especially so the breast oncology is a constantly evolving field. So I was surprised. I was bit out of breast practice for 2 years. Then after 2 years, I realized I had to attend a meeting. I realized things has gone drastically different, and it's very, very difficult to update with this specialty. And this topic being a recurrent breast cancer, I think again there is one single management protocol. There may be difference of opinion, and that's always it's good thing for the candidates. That's why in exams, recurrent cancers are usually not kept when you have a primary case. Again, this discussion was a very good level discussion, and Nisha did a very good job. Thank you. I was inquiring about you in between calling up Srijan, and it is good presentation, good protocol. It not only shows you made a presentation well, it also shows that your current institution, the management of breast cancer, especially recurrent breast cancer, is of world standard. Thank you very much for that. And coming to the candidates, I really appreciate you people because you did very well, and especially when Radha deviated against Vani Parmar's opinion when she said endocrine treatment, you said about chemotherapy for the first case. That is something which is really good, even though an egoistic examiner may not be like in actual exam. But again, it's as I said in the beginning, it's recurrent cancer, and different opinions can be entertained. And this moves into lot of medical oncology, and new drugs are coming. And I am sure that for a general surgical oncology candidate, knowing all these nuances about the latest drugs is going to be a little tough. But you should know the basics. And after all, it is a very good day for us. And I request, I congratulate Srijan for doing this job. But I request you to go back to the primary cases again, rather than going for recurrent oral cancer, recurrent breast cancer, recurrent GI cancer, because recurrence, when the examiners may not be testing these candidates from general surgical oncology background to that extreme level, because this kind of discussion should happen in a specialty exit examination for a breast cancer fellowship after surgical oncology. So it's better to go back to the cases, revisit those areas which is already done 2 years back, because everything has changed drastically a lot. And I am proud that IASO is is doing this program, which is not only informative, but it is also going to be permanent record in YouTube for people to watch again and again and to come prepared for the exams. And as an examiner, I have noticed a significant improvement in the standard of the trainees, especially the national board trainees who are getting training in centers with not much of academic environment. And this is a really good attempt for IASO, and really as an IASO secretary, I'm really proud of that. And I thank you all for this joining. And I also thank all the delegates. Even now we have 50 of them logged in. And I thank you all. And I hope you are going to, all who are going to appear for exam will be clearing in flying colors. Thank you very much.
Thank you, Dr. Chandramohan. Thank you everyone for logging in. This is all from us today. We wish you a good night. Thank you.